Hello, I'm Mark Pegram. I'm a medical oncologist at the Stanford University School of Medicine and the Stanford Cancer Institute. I'm the Associate Director for Clinical Research there and a member of the Breast Oncology Program. Now, let's say that you've finished your primary treatment for a newly diagnosed breast cancer, which may include surgery, radiation therapy, maybe chemotherapy, hormone therapy, HER2-targeted therapy. How will you know after completing all of that treatment that the cancer is truly gone? Turns out this is a very simple question, but a very complicated question because we don't have sophisticated tools in the clinic to completely rule out the possibility of maybe microscopic residual disease, let's say a few microscopic cells somewhere in the body. Imaging techniques like CT scans or bone scans or PET scans cannot pick up those tiny deposits with any resolution. Circulating tumor DNA is an improving technology that is getting better and better at detecting microscopic residual disease, but even it is not sufficient generally, and it's not routinely clinically available, and has not been shown in validation studies to improve outcomes. So the best measure is time. Um, Time will tell. The longer you are out from your original diagnosis, the less likely the tumor may come back, but that probability never reaches zero because breast cancer can relapse after decades, even in some cases. And so you never really know until you live to a ripe old age. So during that time, the clinical follow-up consists of routine histories and physical examinations about every 3 months for the first couple of years, and then about every 6 months thereafter. These routine follow-up exams can be done by a medical oncologist or a surgical oncologist or radiation therapy, or even a good primary care doctor like your gynecologist, for example. You don't need to see all those specialists at each of these 3 month or 6 month intervals. Just see one or the other. If you've already seen your medical oncologist, then you may not need to see a surgical oncologist in follow-up. Also, you'll continue to get annual breast imaging if you've had breast conserving surgery. This may consist of mammography annually, or for certain high-risk patients, for example, those with BRCA gene mutations, or those with greater than about a 20% lifetime risk of breast cancer. Sometimes we alternate mammography with breast MRI imaging with an alternating staggered schedule every 6 months. So you get each every year, but every 6 months you're getting one or the other. Indeed, the American Cancer Society also recommends that women at moderately increased risk of breast cancer, let's say 15 to 20% range, talk to their oncologist about the possibility of adding breast MRI screening to their yearly mammography. And according to American Cancer Society guidelines, even women who find that they have a lifetime risk of breast cancer of about 15 to 20% might also consider this approach. There are risk assessment tools that are available online that consist mainly of family history, personal history of breast cancer, prior history of precancerous conditions like ductal carcinoma in situ, for example. Lobular carcinoma in situ can be a marker of future risk of breast cancer, so that could increase your risk. Or abnormal breast changes like ductal hyperplasia or lobular hyperplasia, or sometimes patients with high breast density might consider these alternating approaches of MR with mammographic imaging. There are these computer models that your doctor can use, like the Tyrer-Cuzick model, for example, that can help decide what level of risk you may have and whether you should consider that approach. Blood tumor markers are not clinically indicated. They do not impact outcome in large studies with long follow-up. I mentioned circulating tumor DNA is still investigational and needs more validation, but it is an emerging technology that has some promise. Serial body imaging like CT scans, bone scans, PET CTs have been shown not to improve outcome. And so they are not recommended if you've had complete resection of all of your breast tumor and have completed all of your postoperative therapy. Those types of scans in asymptomatic patients with normal laboratory parameters are not useful in large randomized trials. Finally, I personally like to review some routine laboratory parameters periodically, since they can sometimes offer clues about relapse. For example, changes in liver function tests that you can measure easily in routine blood work. Low blood counts could be a clue. Increased calcium can also be a clue, for example. So sometimes I like to add that along with the history and physical exam. So the follow-up is actually quite simple. though the question of are you truly cured has to wait to withstand the test of time.